Good morning all. It's Thursday the 9th of July and it's a quarterly hearing with the Health Panel and the Scrutiny Panel. Hopefully you'll be able to connect with us in our new virtual world. I'm Deputy Mary Lahegara from St Helier and I'm the chair of this panel.
I'm Deputy Kevin Pamplin and I am Vice Chair of the panel.
Deputy Jess Sutherland, member of the panel.
I'm Trevor Poynton, Deputy St John, member of the panel.
I'm Deputy Karina Alves of St Helier District 2 and I'm also a member of the panel.
I'll now ask if those that are going to participate in this hearing, if they would introduce themselves. Thank you.
Thank you, Chair. I'm Deputy Richard Renouf, Minister for Health and Social Services.
Senator Steve Powell.
Assistant Minister?
Yeah, Steve Powell, Assistant Minister, Health and Community Services.
Hugh Raymond, Assistant Minister for Health.
Caroline Landon, Director General, Health and Community Services.
Rob Sainsbury, Group Managing Director, Health and Community Services.
Jo Poynter, Associate Managing Director, Modernisation for Health and Community Services.
And as I said before, we expect to be joined by Mr. Patrick Armstrong, our Medical Director, and Steve Skelton, Policy Director.
Okay, thank you. We'll kick off then if everyone's ready to go. The first person that's going to ask questions will be Deputy Pamplin.
Thank you, Chair. Good morning, Minister. Good morning, everybody. Minister, we're first line of questioning. We're going to quite rightly start with COVID-19. And first question, Minister. Minister, who has the lead on the safer travel guidelines policy and in fact, indeed, the overall policy of where we find ourselves now following the debate last week?
The lead sits with me, I understand, because the policy is around a testing procedure, which is, of course, a medical function carried out by HCS staff. But it is true, it's one of those issues that spans a variety of responsibilities. So there's an operational aspect regarding the ports and their general policy issues too.
Thank you, Minister, for that answer. Bearing in mind what you've just said, can you explain why, if you are the lead, as you explained, why the island didn't hear from you as the Health Minister in response to the couple of instances we saw over the weekend, which caused, it could be argued, great anxiety, and indeed the situation with the harbours. And in fact, we didn't hear from any government minister. The private individual who was brought in, succumbed to help the service, was put in front of the media and respond, and indeed the Director General of Home Affairs. Do you not think the island should have heard from the Health Minister, as you've just explained, is the lead on the policy?
Can I just clarify, Deputy, which events you are referring to? So are those the positive tests that were conducted or the incident with the clipper?
Yeah, all of it. All of it.
All of it. Okay, because the clipper was Monday, wasn't it? It's because communications, as you will be telling us, on Tuesday is so vitally important, and that the communications was handled in a different way. I was involved with those communications.
You say you're involved, but do you not think the island should have heard from the Minister, as you explained, is the lead for the policy and indeed the overall testing and all of that, as you said? In hindsight, do you not think that maybe the Health Minister with the lead responsibility should have come and reassured the island, not private individuals supporting government? And I know, as you explained, the Director General of Home Affairs spoke, but do you not think in hindsight that could have been you?
the Director General for Home Affairs spoke about the Clipper incident, which was an operational matter. So I don't see why it was necessary. I mean, ministers were ready if there were further questions arising, but it was an operational matter. It's not that the strategy had changed, the policy had changed, and it's quite right that officers should respond, and I think they responded well and explained the situation operationally.
I get that, but I guess I'm sorry to go on about this point, but so did you have no choice as health minister to say, I think the island should listen to me because I'm the health minister, I have the overall responsibility, or were you simply told, Minister, we don't need you to talk, it was unnecessary? Just so we're clear, just for the public watching, who made that decision that you were not talking to the island after those incidents over the weekend?
Well, I don't see this is an issue about individuals. It's an issue about a government operation. So there was a glitch with the operation at the harbour, which meant that Clipper passengers thought they could be tested when the plan was never to test them, as we've learnt at that stage. So that's not necessarily a matter for the health minister to respond to. It's not within my area of responsibility to organise the operation at the harbour and organise essential travel. That has always been conducted centrally for weeks now, the essential passenger arrangements. So I think there's too much of a concentration perhaps on individuals involved. The real question is communication, whoever it comes from.
Agreed, but as you stated at the original answer, you are the minister, the lead of the policy, and so that's why I was making that point, but you've given your answer. But on the explanation...
We've lost you here, Deputy.
Sorry,
can you begin your...
Yes, of course, I believe, and apologies to members of the public, we may have a bit of technical differences, but hopefully you can hear me. What's your explanation of the breakdown of what happened over the weekend, as far as you understand it, with the islanders arriving via the Clipper? And what's your concerns, because it was always the risk, wasn't it not? And others have spoken about this, the medical officer of health, but there was a positive case, asymptomatic, on the first flight. There was another one on the first ferry. So what are your concerns? Put aside how good that the testing picked those things up, we know that, but what are your overall concerns at this stage of where we find ourselves?
So you've raised two issues there. Those were the positive tests and the Clipper incident. If I deal with the positive tests first, we'd always said we would expect some positive tests to come in. I've checked with members of STAC and the advice has not changed. Those positive tests don't change their view that it is safe to open the borders. So that is not any failing of government or anyone at all that some positive tests entered the islands. We have positive tests with positive persons already in the island, we know that. And it happened, yeah, it was remarkable, but it happened that they came in, one on Friday, one on Saturday. But hundreds of people have passed through the ports since last Friday, and there have been 2 positive tests. And as you said, Deputy, it's clear we are conducting tests quite rapidly and you know, picking everyone up. Everyone is being tested that needs to be tested. As to the Clipper, I think there's been many explanations of that. The Clipper has always been the route into the island during the pandemic for certain essential workers, because we know some people, perhaps for medical reasons, do not fly. So some have been coming in together with our essential freight. And What we didn't know was that there were quite a few excess numbers on the clipper that day, which I think was related to the French industrial action at St Malo, and they couldn't come on a planned route, and they had been put on the clipper. So there were more than the usual dozen that might have been expected, maximum of a dozen. And there was confusion over whether they would be tested at the ports or the usual arrangement that they would be asked to go to the airport testing centre the next day. And we know now how that confusion arose.
After that happened, just take us into your department. When those things happened, did you contact the medical officer of health and get an update and from the advice and the information that was explained to you and then to us, and say, could you update us where is your, and test the evidence that was being provided? And indeed, the medical officer of health is not with you alongside. I'm not going to ask where she is. It's up to you, obviously, who you bring to the hearings. But I just think for the reassurance again, which I keep going on about, I think the public were needing that reassurance, and just what your thoughts are on that.
Well, the medical officer of health is on leave, but we will have Mr. Patrick Armstrong shortly, who is our senior medical officer, senior medical director in the group. So there's no question of not being able to give reassurance, and I want to move away from personalities here. It's about the right response and not a particular person to give a response.
Okay, on that, let's move away from it then and come back to when others join. There's some concerns about the overall costs of the antibody testing kits. We were started to be told about these by the Chief Minister back in March when we were at Fort Regent, and the island were learning about the possibility of what those antibody tests at the time could bring. As we know, they were purchased via contact to the UK company and also elsewhere. So can you now, what is the total money that was spent, can you tell us, on all the antibody testing from way back then? But also, could you say how much money has been lost, you could argue, if they haven't been used? So how much money overall has been spent on the antibody test, and has there been a loss?
Deputy, I'm afraid to say I would need notice of that detailed question, so I can't tell you offhand the total budget on antibody tests. You began your question by saying there's concern over the cost. No one has raised concerns with me. If you would like to put your concerns in writing, we can obviously look into them. But
the concerns, Minister, have come from members of the public who engage with Scrutiny, as you know, and before we do these hearings, we do ask the public to ask us any questions relating to the subject matters we send you in advance. And the antibody testing, we've had some engagement with the public who have quite rightly put their concerns to us, which is what we're doing. But if you can get those answers at a later date, we'd appreciate that as well.
Okay, I believe it is valuable to conduct the antibody tests. And we have received funding to combat this pandemic. There's never been a question of we should not pay for this. What public health has needed has been forwarded, has been provided by the Treasury to deal with this pandemic. I'm pleased to say, and you'll be pleased to know, Dr. Muscat has now joined us, and I wonder if he wanted to contribute to that issue, Dr. Muscat.
Hi.
We could just about see you, Ivan.
Okay. Shall I move somewhere?
Maybe if you can swap with the Director General, if that's possible, so you can get comfortable and set. And just remind members of the public, this is a live quarterly hearing with the Minister, and the Health and Social Services Scrutiny panel. We've started by asking a range of questions, and we will move on to my colleagues to talk about other subjects of mental health and the Jersey care model. But as Dr. Muscat, you're with us, and for the first time in a quarterly hearing, you've met with us privately, and now you're here and the public are watching. Can you first, before we get back to the antibodies testing, can you give us now, in your opinion, where we are as an island and your overall summary of how we performed since January the 22nd?
We are in a reasonable position, I think. We have capped the significant COVID activity that was apparent in the winter months and very early spring months, and did so ahead of many European countries. The COVID activity currently is very low indeed on Ireland, and it is only being perceived at the moment as a result of the proactive screening that is being undertaken at a fairly reasonable rate in order to pick up, if you like, hidden asymptomatic infection and contacts of such individuals. So we are actually going out seeking fires, in inverted commas, to put them out before they become apparent, if that's the right analogy. Given the low rates in other countries in Europe currently, COVID is still present in these other countries, but the rates are relatively low. Then the side effects of the mitigation factors, the restrictive mitigation factors that were put in place to manage COVID, started to weigh more heavily in the equation, and it seemed reasonable as a result to dial down on these restrictive practices given the overall COVID situation. So we have moved from level 3 to level 2 within Jersey, and the borders have been opened under various regulations to allow individuals to see their families in the UK and vice versa, and for people who perhaps were stuck abroad because of the generic lockdown to return to the island if this is was their place of residence. So I think all in all, we have managed to control COVID so far. We haven't got rid of it, of course. I am not for 1 minute saying that, but we've managed to put a cap on it. We are testing quite frequently, and of course contact tracing in relation to that, to prevent as much as we can any re-emergence of COVID. And we are also dialing back on the restrictive mitigation that had been put in place to allow for more normal activity, but we are not, absolutely not back to normal. COVID is still there. We still need to pay attention to it as a threat. We still need to ensure there are countermeasures.
Excellent. And Dr. Muscat, and because you're here again, the public who engage with us and definitely engage with me, and I'm sure you're hearing this as well, have been totally consumed by a novel virus like no other occasion before, because of social media, 24-hour news and information. People are generally obviously concerned about the second wave. Can you update us based on your information and the way you see it now? Will we see a second wave, do you think, to the best of your knowledge, or how do we prevent a second wave? Because I think for the reassurance of islanders, that is a big point going forward. So your thoughts?
there is a distinct likelihood of a second wave when we go into winter, because respiratory viruses as a whole are more common in winter, and this is a respiratory virus. It's also a gastrointestinal virus, and some gastrointestinal viruses, for example, norovirus, which classically is named winter vomiting disease, is also more common in winter. So we should expect that if COVID is going to cause a second wave, it is going to do so in winter. Indeed, if you look at the southern hemisphere now, which is their winter time, of course, then places in South America and South Africa and one or two areas in Australia are seeing an increase in COVID. So we will need to be even more vigilant and more careful as we approach winter time, and we just need to bear that in mind. The other thing that we need to bear in mind, of course, is that all respiratory viruses are commoner in winter, and that includes flu. And I would very strongly encourage all those who are eligible for free flu vaccination to be vaccinated as soon as possible this coming season. And more flu vaccines have been requested to help cater for that. There was a second point, I think.
No, actually, you've answered the main bulk of it, Ivan, as you always do. My final point before I return to the Minister is this whole thing about herd immunity. If we go right back to February and March, and we're watching what the United Kingdom were doing, and we could sit here and talk about that all day, and other parts of the world, and it's difficult, is it not, to compare, but we must focus on ourselves. But the other concern that people are raising and bringing to us, and I'm sure you're hearing it again, is this herd immunity about, are we just letting the virus into the island to get everybody affected so we can use the Nightingale Hospital, so we can get everybody immune? You've explained this to me, but could you now just use this moment to explain once and for all the thought about all of that?
Sure. So at the very, very beginning, before people had any real feel for COVID, there were parallels being made with other viral infections, and the possibility of having controlling the bulk of COVID infection and only letting small numbers trickle through in order to gain herd immunity safely. I think all thoughts of herd immunity quickly evaporated, and we focused on just dampening down infections and the problems caused by COVID, but we wanted to measure how much COVID was going through the population, not just by noting the symptomatic cases, which of course always came to light and were diagnosed and so on, but by also noting the asymptomatic cases. And that's where the seroprevalence studies came into the equation, and as you know, we've done 3 now seroprevalence studies, which continue to show an exposure rate of about 4 to 5%. So that's single figures, 4 or 5%, not 45, of course. And so the infection rates in Jersey have actually been relatively low compared with some parts of the UK, for example, where the seroprevalence rates are closer to 10 or more %. So that, if you like, is another measure of the degree to which we have managed to put a cap on COVID activity in Jersey. But it does mean that most of our population are not immune to COVID, and we've got to be careful of that. It does mean that we've got to be careful to pick up any infection as soon as possible, isolate those people, and contact trace in relation to those people. And that's what we're doing at the moment. But at the moment, we're doing it perhaps more avidly than we did in winter, because we're actually going out looking for cases.
And that leads me to my final questions. How many tests are we doing at the moment, and how does it break down between the travel testing that we're doing and the workforce programme? And what is the update on the turnaround of testing times? And I hope somebody's making a note of all my final questions, but how many tests are going off island and how many tests are happening on island? And finally, could you give us an update on the increased test kits that you were telling us all about in the press conference and to members in terms of boosting those numbers? I hope you got all that. That's my final question, and then I'll hand over.
Okay. So I believe at the moment we are probably exceeding the 500 a day with the borders testing. I can't give you an exact number because I don't actually have it off the top of my head, so I apologize for that. But I know that many of the off-island tests are coming back to us within 24 hours. Not all of them, but many of them. Many of those are going to a particular laboratory in the UK, which is dealing with the bulk of our off-island tests, are coming back to us within 24 hours or just over that. The vast majority come back to us within 48 hours. There are occasions when there are problems either with transport or more often with IT, where there is a delay in the results coming back to us, and that happens, you know, once every 2 to 3 weeks. There's a glitch happens somewhere in the system, and we have to obviously cater for that and try to ensure that such glitches are not repeated. But new glitches come along in life as always. We currently ration ourselves to 65 tests on island per day, which obviously some days we do more, sometimes we do less, but that's the average, because that's the number we can knowingly replace going forward. And we use those on island tests, which give you a result within 1, maximum 2 hours, for emergency admissions, emergency transfers, and sort of acute, if you like, medical care, rather than for simple screening purposes. In terms of where are we going next, we want very much to have a more large-scale on-island PCR testing, and we are in the throes of bringing in sort of a self-contained laboratory, which will be, if you like, annexed to the hospital laboratory to undertake PCR tests at a rate of about 1,376 tests every 8 hours, if everything goes swimmingly, which will be about 2,600 every 16 hours, which would be a reasonable sort of work day. We are hoping, if all goes to plan, we are hoping to receive that self-contained laboratory early in August, have results starting to come out later in August, and have full capacity in September, and most definitely ahead of the winter season. And the thinking behind that is both borders and winter, in my mind. At the same time, we obviously, whilst all this is being set up, we will continue with off-island testing. At the same time, we will be looking at other technologies like the LAMP PCR technology, which will give you results within about 1.5 hours, 45 minutes extraction, 20 minutes testing, and that is a rapidly developing technology, which is really very attractive, and so we are keeping a close eye on that. A third option, which has only really come to light in the last week, is the concept of pooled testing. So the on-island test is run 1 sample per cartridge, which is 65 cartridges a day. But you can, in a low prevalence area, such as Jersey, do up to 6 swabs per cartridge. Now that will reduce your sensitivity a little, but it is still a doable thing. And then if you find, so theoretically then, you've got 6 times 65 sort of tests you can undertake. Obviously, if you find a positive in a pool, you would then need to take those that have contributed to the pool apart and run 6 tests to find out who of those is positive. So that concept of pooling is one that has been used in other situations, for example, in blood donor testing in the UK. So it's not a novel concept. It's just novel in relation to COVID. And we are looking at that now because, of course, it will increase our capacity. It's not up and running yet. We are looking at it, I hasten to add.
Of course. Well, Ivan, Dr. Musker, you've just demonstrated why we've been so desperate to have you at these meetings, because in all those answers, you've given reassurance and you've given us answers, and the fact that those testings are looking to increase. So again, the ability to say thank you for everything you've done in the last few weeks and answering all our questions. I'm sure if the public were alongside me right now, would echo those thoughts. Thank you very much for everything you've done. And with that, I'm going to hand over to my colleague, the Deputy St John Minister, who's going to speak to you now.
Thank you, Deputy Pampton. I apologise for coming in very slowly there, but I'm having problems with the technology actually switching sound and camera on. I'm going to ask a couple of questions about the effects of the virus on the Jersey Alzheimer's group of people, those people suffering with dementia. Jersey Alzheimer's has publicly and directly expressed. Are we there?
Yes, I apologise. Do go ahead, Deputy.
Jersey Alzheimer's has publicly and directly expressed its concerns about the information on COVID-19 that they have, and they feeling that they are not they're not offered enough information to be able to share with some of the families depending upon them. Why did you not take the charity up on its offer to assist in simplifying the information being shared with these particular members of our society?
Deputy, thank you for your question. The work of the Alzheimer's Association does mean a lot to me and many islanders. So I have previously apologised when asked similar questions. To be frank, we did seem to drop the Alzheimer's Society in the vast number of other work that needed to be done at a vast speed. And perhaps we didn't give enough thought to the people that they were looking after. So, for example, we could not continue the memory clinic during lockdown. That has had an impact on many dementia sufferers and their families. similarly daycare centres and the like. We would have liked to have worked things through with them, but since their expression of disappointment, we've made contact with them, and we're working with them well. We had a good relationship before. We continue to have that good relationship, and we're very appreciative of the work they do. So may I pass this question to Joe Pointer, our Head of Modernisation, who will be able to give the detail of what we're doing with the clients of the Alzheimer's Association.
Good morning. So we've met with the Alzheimer's Association and take on board, I think the biggest concern they had was things were happening very rapidly, and we were getting very good at getting information out through social media, electronic media, and we hadn't had the time to think about how we get it out in paper form within an understandable way. So we're working with them, and our communications department is working with them so that we can do that better. In at the early stages, in the rapid speed, it was very hard to get everything out in an easy, accessible format for people to understand. I've met personally with the executive of that organisation, and we set up a programme to do that. There were other things that we had to stop during this period, as the Minister's mentioned, such as the memory clinic and some of the work on the dementia strategy. But we've now started looking at how we can do that, even if it is electronically, so we don't lose the good work and the good relationship we have currently with the Alzheimer's Association and some of our other charities and organisations that we work with.
Picking up your reference to electronically, are the Jersey Alzheimer's Association now listed on the Connect Me page on the government website? Because they were not.
So my understanding was that we haven't got charities listed on the Connect Me page, and I don't believe they're there, but they will get directed to Alzheimer's if somebody rings into one of the helplines. They're on the list of organisations that can help and be of assistance.
Well, thank you for those answers. I'm going to move on now to ask the Minister about the mental health services in general. Minister, following Deputy Pamplin's amendment to P61, which attempted to enhance the mental health services in the safe exit, during the safe exit strategy, what is actually now in place to provide the extra support that the adult mental health service requires, given the increased demand for support that we're seeing?
So, Deputy, Adult Mental Health Services has reconfigured its teams in order to be able to provide better support during COVID. That has been explained very well previously in States debates by Senator Pallett, who of course has responsibility for this area. Would you wish me to pass over to him?
That might be the answer, yes.
Yes, okay. So, Steve, may I ask you to?
Yeah, happy to. Morning, panel. As the Minister's just said, you've previously received documents, and I've made various statements in the Assembly around the reshaping of adult mental health services through COVID-19, and also how that will then transition into business as usual services moving forward. The amendment of Deputy Pamplin was an important amendment, and we will certainly be clear in how we are going to improve and enhance services moving forward, and inform the Assembly at regular intervals around what that will look like. I just want to stress, though, that in terms of business as usual, that the mental health improvement plan is something that has been in place for some time now, and the Mental Health Improvement Board oversees any improvements, development within adult mental health services within the island, and that remains the document that that we will be looking to provide improvements within. It's a flexible document. It's one that monitors and RAG rates improvements within the service. But you are quite right. We do need to ensure that we are on top of improving services, and as we reintroduce services such as Jersey Talking Therapies and carry on discussions with the Listening Lounge in terms of what that might look like moving forward, it is absolutely vital that we provide the services that the public needs. So there's an awful lot of work going on within the care group, the mental health care group, to ensure that services are of the standard and the capacity and have enough capacity for the public. So there's no shortage of effort going into it. Perhaps the communication at times could be better, but I think what we intend to do and what the Deputy Pamplin has asked is that communication is better, and it will be, and we will provide regular updates.
Thank you for that, Assistant Minister. Can I, though, you mentioned the Listening Lounge and Jersey Talking Therapies. Jersey Talking Therapies have been redeployed, in effect, and the Listening Lounge has become the first port of call. Come to our attention that the Listening Lounge is creaking under the pressures that it's under, to the point at which they may be considering pulling out of the service altogether because they simply can't manage the level and severity of the burden that besets.
Deputy, I would totally refute what you've just said. I have no information whatsoever that the Listening Lounge is creaking in any way whatsoever.
Well, over the last fortnight, they've had 55 referrals, I gather, and their levels of skill are insufficient to deal with the burdensome cases that are walking through their doors.
That is not the that is just not the information that I'm receiving from the Listening Lounge. Clearly, if cases are more severe or require immediate attention, there is opportunities within adult mental health services to refer them on. The Listening Lounge know exactly the way that that can happen. So I haven't got any concerns that the Listening Lounge is not being able to cope with the level of referrals or people walking in at the current time. It is a difficult time. We all know it's a difficult time as we reintroduce services back in. But the plan is to get Jersey Talking Therapies back up and running in a reformed way, which will again add back into the service. But I have heard nothing from the Listening Lounge to suggest that that's the case. The report we've had from them recently was clear around the levels of referrals that they're getting. We've still got to go through a formal review with them at some stage in terms of what the service will look like longer term. But I'm sorry, I haven't had that information, and I keep in regular contact with them.
Well, will you be contacting them immediately after this meeting to find out where it's at?
I know where it's at because we just had a regular update from them in terms of the amount of levels of referrals that are going through it. We have regular contact, and our Director of Mental Health Services has regular contact with them. If you wish me to speak to them, I'm quite happy to. I speak to the director that deals with the Listening Lounge on a regular basis. If you want me to go down there and talk to her again, I absolutely will do.
Oh, it's not for me to give you instructions, Assistant Minister. It's for you.
Everybody else does.
So can you give us a timeline in relation to when the Talking Therapies unit gets back up and running?
I think it might be. I think it might be better if the director, Rob Sainsbury, probably does that. I know he's been working closely with Miguel and Dr. Garcia in regards to reintroducing that service. So maybe I can hand over to Rob Sainsbury for that.
Yeah, no problem. So we started receiving new referrals again for JTT from the 22nd of June. Our plans to open the services back up for physical appointments so they can actually see people face to face physically will be by the end of July. So between the 20th to the end of July, some of them might start as early as the 20th, but by the end of July we'll have all of the previous arrangements back in place. I just want to pick up on the points on the listening lounge because we're completely aware of the increased activity that is going through the listening lounge. It's almost doubled in June, and some of it is increasing in complexity, but there is a very clear referral process between the listening lounge and JTT and broader mental health services. Tomorrow we have further time with the listening lounge and JTT and our mental health team because we're going to go through that caseload because it is increasing and we are seeing increased activity within the mental health remit. We expected to. That's what all of the preparation that we've been working with the Assistant Minister and our mental health team has been about, because we probably need to divert some capacity between the JTT, the Listening Lounge, Jersey Recovery College have a role to play, Mind have a role to play, and our adult mental health services as well. So we're still working with all of that activity. It's a daily ongoing thing for us.
Interesting that you are aware of an increase in referrals. Is this increase in referrals entirely to do with the COVID-19 period of isolation?
There are links. We're seeing an increasing pattern because obviously we're seeing people who have been impacted on the psychological effect of what's happened with COVID, whether that's financial, employment related, or other circumstances. So we're definitely going to see thematic cases coming through. That's consistent with all other jurisdictions. We also need to be mindful that in some circumstances, for psychological support, because we've been offering virtual support and the listening lounge had turned into a listening line, at times those mechanisms are not always the best mechanism for people. They need to see people, they need to be in proximity for people. So naturally, as the services now start to open more normal as they were prior to COVID, you're going to see those people who want to come in and see their counsellor, have a conversation with somebody face to face. So I think it's a combination of both. I think it's a bit too early for us to actually draw conclusions on all of the activity because we're only just starting to get back to a level of previous BAU, but we are seeing themes, and a lot of that does relate to COVID. We expected it to.
I think just adding to that as well, and I think Rob's sort of touched on it, is that there are a lot of issues, and we're aware of issues. I think we all are around more social issues rather than pure mental health issues, issues that are causing anxiety within people. And I think it's really important. And I know it's been happening that the Listening Lounge are referring those to other agencies where people can get help and assistance, while also providing them with the support to get them through that particular period of anxiety. Rob's absolutely right. It's a mixture of support. Some of it is within mental health services, others are within other agencies within government, and even other private sector agencies as well, or charitable sector agencies.
Well, thank you for that. And I will ask in more specific terms about the response in a self-harming way and the number of suicides that you've had over this period of time, and what your impression is of the state of our population in that sense.
I think if Rob can start on that, maybe I'll comment at the end. But maybe Rob, you're probably in the best position to comment on that to start with.
I think that's quite difficult for us, and the reason that's quite difficult is because when there is an event such as suicide, the review of the events that led to the suicide take a long time to pull together. There's a very detailed review that needs to happen. There's a multi-agency approach we need to explore. And so to review that for the period of COVID, I don't think we're at a position where we can say to you today, we've had X number of cases and this is the output of them. That is detail that will emerge. but we are always in a position with our suicide reviews where they are retrospective, and we monitor them in a very process-driven way. We draw on the Safeguarding Partnership Board if we need to, so we can get that information to you, but it is something that is an ongoing picture that we're reviewing, is what I would say. What I believe at the moment is that our initial impression is that we're not seeing levels that are outlying to previous years at this moment, but it is a bit premature to conclude that right now. We need further work.
Thank you for that. You had a number of prevention initiatives running. Are those continuing to be extended to the community, and the mental health care group, for example, is involved heavily in that, I believe. Have you got some feel for how successful that prevention programme is?
So probably one of the most successful prevention initiatives that we're having at the moment, and this is a COVID-related initiative, is in relation to our vulnerable persons, and these are persons who also are at risk of harm, as in self-harm or potential suicide. It would probably be helpful if I call in our Chief Social Worker, Isabel Watson, who sits on that cell, who is part of that safeguarding process. Isabel, I think it'd be really helpful for Scrutiny if they could understand what we are doing to ensure we try to protect what we believe are vulnerable islanders that could have escalating mental health concerns.
Okay, thank you for that. Hello, Trevor. Hello, Minister. We have introduced, on a positive note, we've introduced a safeguarding cell 3 days a week. This is in partnership with the Safeguarding Board. This is to identify vulnerable adults. And this also links into a lot of the work we've been doing in daycare. The police, we have 13 different multi-agencies. We've been working closely with all the other agencies on the island. I would say the COVID-19 process of the safeguarding cell has been a great success. We intend to continue that going forward, not just through COVID-19, and this good practice, bring it into the future. I would say the safeguarding cell has strengthened our working relationship with adult social care, the police, all together in identifying early prevention. We've started to take data on how this is working, and people are saying how well we're working together, and we've looked at identifying needs. We now have a presence of mental health attending the police 5 days a week. We go to that daily meeting and we feed back any adult protection notifications, and I would say we're being more proactive than we've ever been. When I started in January, the plan for the Jersey Care model was to bring cells like this together. I'm really focused on joined up working and sharing information, because I feel that's where we can get it right for vulnerable adults. On the back of COVID-19, bringing this cell together, we're maintaining that. We're not going to stand that down. I want to continue that because I think it's good practice for the island, and it's good to have the connection with the private sector. So I would say it strengthened our relationships with mental health, and we've been trying to pick up the pieces and the increased demand for mental health by our adult social care and social workers carrying a lot of the cases that are required. So I'm hoping I'm giving assurances there, and I think it's about regular contact. We've also have a good working relationship with children's services. We're looking at reconfiguring front door services and how we respond to people in a timely way. I hope that helps.
Yeah, yes, it does. Thank you very much for that. I'm conscious that we're almost an hour into this meeting and we still have quite a long way to go. So I'll hand you over to Deputy Jeff Southern at this stage. Thank you.
Thank you. Right, and I'm on to a different case, the Jersey Care model, and the question is, where are we with the timescale, seeing the final version, strategic outline case, and the government plan some sort of business case for where we're going? Minister.
Thank you, Deputy. I'll ask Joe Pointer to explain the detail of the timetable.
Thank you. Work has continued in this period when things have been difficult. I'm going to work backwards, so we're still hoping to go to States Assembly on the 20th of October, which means we need to have lodged the Jersey Care Model Proposition by the 7th of September. We intend to have our business cases ready to be lodged with the government plan. So the strategic outline case is proposed to be lodged, go to COM on the 2nd of September. So the plan 2nd of September to go to Council of Ministers, lodging on the 7th of September, all the financials, the business case in the government plan, and to the Assembly on the 20th of October.
And that is the business plan, so we'll be able to see what the costings are of delivering the Jersey Care model.
The business case will be part of the financials within the government plan this year, so yes.
And won't be extra to the government plan. And
no, the plan is that the Jersey Care model business case will form our submission for the government plan.
Uh-huh.
Not extra, not in addition.
Okay. And the impact of coronavirus on progress, how has that been? What have we seen since we last met in February? Can we talk about that at all?
So the impact has slowed us down. We would have liked to have had this lodged a lot sooner. We would like to have had everything out public now, but we haven't. That's why those timescales are very tight. Work has continued in the background, but we're not ready yet to have a public document with a business case. We're still working on that.
To the Minister, could you explain what happened in response to COVID-19 that's diverted us, and how you've coped in the last 5-6 months?
Well, it's around the availability of personnel to work on developing the plan. Some staff were...
Specifically, how are we done with the GPs? That was as part of the response to COVID, and separate from the business.
Sorry, how did what with the GPs?
How have you managed working with the GPs under this special arrangement?
It's worked well. We've been able to deliver the urgent treatment centre, and GPs have worked with the ambulance service and in care homes. So what I'm being told by both HCS and GPs is that they've each had valuable experience and gained an understanding of each other's work. And it was the right move to make as a response to COVID. We were better prepared as a result of entering into that contract with the GPs.
Okay, but we were told recently that this contract with the GPs will not be renewed in August. I think it's August the 6th when it finishes. How do you feel about a return following that to £45 to see your GP? Is that surely not a step backwards?
That was the decision of the GPs not to renew that sort of contract, which was negotiated in haste and was specifically designed to respond to a COVID emergency. But we're now in a position where we can talk with the GPs about wider issues, about the better delivery and more coordinated delivery of primary care in the island. And that is what is happening. So whilst they will go back to their surgeries, we are still talking very productively with them about how to transform care in the island.
You say it's very productive. Are you not disappointed that you've had to return to £45 to see your GP, and that a replacement, a renewed contract, was not able to be negotiated?
Well, Deputy, I mean, I'm not in a position to control what the GPs charge to their clients. We can control the rebate that is offered through the Social Security process and the Health Insurance Fund. But the question of what they charge is for them as private practitioners.
But you successfully negotiated a 4-month contract following the outbreak of COVID. Are you not disappointed? I repeat the question. You're not disappointed to have to return to a £45 consultation fee and have been unable to negotiate once more around a sustainable service and not this unaffordable service for some?
Well, it's not simply a question of cost. The contract took GPs into public employment for a limited period, and so being employees, they were no longer running businesses and needing to charge fees. So therefore, we had the ability to set charges. But when they're no longer government employees, we are not in a position to direct how they should charge.
Are you saying then that you are unable to assure us that the £45 fee will not be there permanently? You say you're still talking to the GPs, and you're saying that that is productive. When do you expect to see a new case to deliver sustainable service of primary care?
So, Deputy, my wish is to improve access to primary care for all, not just vulnerable groups, and to remove barriers to access. And there are ways of doing that. And I mean, one way, in extremis, would be to take them all back and make them compulsory employees of government. But that's not what we want, and that's not what they want. So I think that's very unlikely to happen. But there are methods which we can use to deliver services in an accessible way, and we're exploring that, and we're making progress with them.
And you are requested by P125 of 2019 to identify and prioritise groups of vulnerable people who are either financially, socially or clinically vulnerable. How is progress? Could you tell us about what you see about those 3 vulnerable groups?
Yes, and we are working on that, and we were pleased to give you a short briefing on that yesterday, Deputy. So we are looking at those different groups, obviously those on low income, children, but specific long-term conditions such as diabetes. Well, the diabetes care has been transformed this year in that there's a significant amount of funding that has gone into making diabetes care more accessible. But there are other vulnerable groups like that may not be financially vulnerable, but they're vulnerable because they need an enhanced degree of care. So as your proposition requested, and as the government plan undertook in advance of that, those groups, all those vulnerable groups, are being looked at with a view to coming back to the States and having a new system in place, improving accessibility from next year.
And that's and how confident are you that you can bring a scheme to encompass those basically 3 groups in order to be in place by January next year?
Well, yes, I am confident. I am confident because we are conscious of the timetable. I would very much want to keep to that timetable. And you know, there's no opposition to this, Deputy, in that we all know what we want to achieve, and we must work out the system arrangements behind it and secure the funding.
So when will we see who those groups are and what the arrangement is? Do you know?
So the plan is to bring a proposition to the states. I think it's in Q3, is it? Do we? Yes.
What it says in the proposition.
That's what it says in the proposition. So we're keeping to that timetable, and the plan will be fully developed by then.
And we'll see that in the business case in the government plan.
Yes, that will need to be included.
On September the 2nd or thereabouts, 7th maybe. Early on in that.
Yes, it's obviously, you know, expenditure next year and onwards needs to be included in this government plan coming forward.
Okay, I think that covers what I wanted to ask about in some depth. Okay, so can I pass on to Karina?
Just before that, Deputy Southern, and before Deputy Alves, just to push you further, Minister, just confirm that the business case for the Jersey care model, you're saying it's going to be part of the government plan, which is not due to be lodged until the 12th of October. So if that's the case, going by a quick rough calculation, there'll only be 2 weeks for us to scrutinise it before the Jersey care model debate on the 20th of October. Have I got that right?
We'd wish to give you as much time to scrutinise as is possible, Deputy. And of course, in all those timetabling, we'd want to liaise with the panel, because I'm conscious you'd want to prepare a report probably, or at least comments, and ask questions and possibly hearings and the like. So,
Minister, we plan to lodge on the 7th of September, so there will be more time for scrutiny prior to debate on the 20th of October.
That's the Jersey care model.
Jersey care model.
Yeah. I don't know if you heard that. We plan to lodge on the 7th of September.
So I guess, so Minister, all I'm saying, I guess, if you're planning to lodge on the 7th of September, and you know we've been reviewing the Jersey care model, I cannot stress it enough how early we must see things. If that's the case during the summer recess when we're still going through the pandemic, and all I can stress and urge is that we see things as soon as possible. But the point I'm saying is that the Jersey care model is going to be part of the government plan with your version, your department in there. Why is it not being separated? Because it's as on record, as you said many times, this is something that's going to take years to sort out. So why is it not being done separately? Again, if you can clear that up.
So my understanding is that the Jersey care model will be looking far ahead, and consider funding longer into the future. The government plan will concentrate on the immediate funding needed to put into the first phases of implementing the Jersey care model. But we'd very happily try and work through this detail with yourselves as a panel and your panel officers, and whatever improvements we can make to the timetable, we would try and work with you.
Okay, this is something I'm sure we will come back to, but I'm aware Deputy Alves has been waiting very patiently, so I'll hand over to Deputy Alves for her line of questions.
Can I just come back for a point of fact? Is it the case that the 4 months trial or the 4 months agreement with the GPs that's recently ceased, how much did that cost? Was that £5.3 million?
Lauren, could you just confirm that? I thought it was 4.7.
Yes, of course. It's Lauren Jones, Head of Finance Business Partnering. Yes, it was 4.3 because the cost was offset by the patient income.
Okay, thanks.
Okay, thank you. So I'm going to be asking some questions about the running business as usual at the hospital at the moment. So we note the news that visitors can now return to the hospitals. How has this been allowed, and how will this work while the island still has active asymptomatic cases on the island? Thank you.
So, Deputy, I have discussed this with officers. The fact that visitors weren't permitted was a source of concern to many who wished to see their loved ones in hospital. Equally, it is a source of concern. We didn't want to create undue risk around COVID, so it was a difficult area to manage. But in my discussions with officers, I was satisfied that what has been set out now as the procedure is appropriate and safe. But I'd like to ask Dr. Muscat, perhaps, if he'd address the detailed reasons as to why that is, let's say, safe in COVID terms.
So, this move was basically in keeping with the generic move towards softening mitigation and returning to something closer to normality, but while still taking appropriate precautions. So the number of visitors that we're allowing per patient is, I think, something like 2 in total, and those visitors need to be consistent. It's not different people on different days. Visiting hours are controlled, and this is also in keeping, of course, with visitors to residents in care homes who have essentially been shielded very thoroughly over a 3-month period, but as a result of which have not seen many of their relatives. In terms of the overall sort of protection of the hospital, all admissions, whether they're emergency or elective, are screened for COVID, as well as using tests. They're also screened symptomatically, of course, and staff are part of the proactive surveillance system that has now been up and running for a number of weeks. Frontline staff are tested every 4 weeks. Staff that are not quite in the front line are screened every 8 weeks, and care home staff fall somewhere in the middle, and they're screened every 6 weeks. So those are the sort of protective layers we've established to try to protect patients and staff whilst permitting some closer working to normality.
Okay, thank you. My next question is, what services within the hospital are back up and running, and where are there issues? For instance, can you confirm what the situation is with the Samarais ward and all the physio services? Thank you.
Yes, Deputy, last month we began day surgery work, and that has proceeded well, I understand, with more day surgery being carried out than possibly pre-COVID, and a greater number of procedures, because practitioners have learnt that they can do that. And then we are now opening up for elective longer stay surgery. I recognise there's been discussion around Samarais ward, which was closed as a result, as a COVID measure, but we are still looking after those necessary patients that need rehabilitation. And as to the detail, I would like to ask Mr. Sainsbury to address that, please.
Thank you, Minister. We're also starting to do some of our more major elective surgery now at the hospital as well. So we've started our theatre schedule getting back up to normal. We're also starting to introduce some of our outpatient appointments across different specialties. But you specifically asked as well in relation to what's happening with Samarais ward. So at the moment, Samaray remains temporarily closed. We closed the unit prior to COVID, and there were 17 patients on the unit. We've now tracked the detail for those patients, and I've agreed I will share that with Scrutiny, and we'll send that to you today. The alternative in providing rehabilitation support from an inpatient perspective is now provided at the General Hospital. So we've opened a dedicated area within the existing ward capacity at the hospital. We started with 6 beds. We had low occupancy for those beds in the first few weeks. This week we've had slightly higher level of occupancy. We'll probably increase those beds, but we're still not at a position at the moment where our bed capacity and our emergency activity means that we need additional beds. So we wouldn't have the volume at this moment to reopen Samaray ward. We're still managing to complete inpatient rehabilitation within the one site in the General Hospital. And that's going quite well. We're seeing good outcomes for those patients, similar to what we would have had in Samaray. And again, I've agreed that we will share that detail with the Scrutiny panel, so you can see where the destination for those patients on discharge is, whether it's home, whether it's into long-term care, or whether it's onto a different care facility. So we'll provide that detail for you. But that does appear to be working quite well for us at the moment, working with our community colleagues. I think it's fair to say the hospital is seeing some increasing activity. Our occupancy is a bit higher than it has been previously, but it's still not at the level we were pre-COVID, and that's consistent with the UK and other jurisdictions. We're not seeing the same number of emergency admissions and the same volume of activity coming through our front door.
Thank you for that. So actually following on from that, my next question is about waiting lists. So what impact has the pandemic had on waiting lists? And how long do you think it will take to address the waiting lists that have increased as a result of closure of particular services? We've recently heard that from a member of the public who states that there's a 6 to 8 month waiting list for a colonoscopy, which is obviously causing some anxiety if there is a suspected tumour or cancer growing. So how is that being dealt with?
So we've continued to provide urgent appointments and intervention for patients throughout the COVID period. So if people have needed to be referred for urgent cancer pathways, for urgent treatments, if they needed urgent surgery or urgent biopsies or urgent action, we've continued to provide those services. I'm not aware of that incident, so I can look into that. I'm aware there's been some social media reference to it today, so I'm going to look into that query, of course. But we know that COVID has had an impact on our elective activity. We've not been able to continue with the same level of routine work and the less higher acute work throughout the period because we've had our hospitals being disrupted by this period. We are confident, though, that with our new schedule going forward, our recovery plan, we can get back on top of our waiting lists. And we're making some good progress in some of our specialties to manage that. That means we need to work differently. We need more day surgery activity. We need to make sure our theatres are scheduling in as much volume as they can. We've separated our public and our private work very clearly so that we can really drive our public waiting times and start to reduce them across specialties. So we're going to be more transparent about that detail and that data, but we are now starting to get back on top of that waiting list position.
Thank you. So my next question is, how much longer will the UTC remain at the hospital? How will this be staffed? And how much is it costing to run, or how much has it spent to date? Thank you.
So I can answer that. I can't answer the cost detail for that at the moment because it's a combined absorbed cost. So part of the function of the UTC will be from the GP input that we have, but there are a lot of redeployed staff within the unit as well. So we've got a mixture of staff from across the hospital and different settings working within this. So the costs will be difficult to separate out. We will get to that, but I don't have that to hand at the moment. In terms of the facility, we are looking, and we're doing this piece of work this week about how we can start to get back to normal, and we're looking about how we can start to have our flow of activity back through our emergency department in a safe way. So we're working with the ED department and the UTC this week to look at how we can actually start to change those pathways back to the previous pathway, and we're going to actually review where we've got to with that today so that we can start to make those finalised plans around that. It's always been our intention that we start to have our activity coming back into the emergency department, but we need to do it in a safe way, in a socially distanced way for patients who are waiting. So we're just finalising some of our plans with that at the moment. I think it's fair to say that as our activity in the hospital is starting to become a little bit busier, we need to be conscious that the GP activity is also getting busier. So GPs are saying to us that their practices are now starting to get a bit busier and they need to focus their time on that. So in responding to that, we've had to make sure that we balance our GPs between the UTC and those practices going forward.
Okay, thank you. I'm mindful of time, so I'm just going to jump into, hold on, I think Deputy Southern would like to ask a question, so I'll let him interject.
Yeah, just briefly, because I'm my own ignorance, what's actually the difference between the UTC and using accident and emergency? I thought one of the problems was too many people were going to A&E. So what's the difference in treatment?
No, our response in establishing the UTC was because of the potential impact of COVID. We had to make sure that the ED department had sufficient ability to manage what we would call hot and cold patients coming through the department. And at that time, that volume of activity could have put pressure on that department. So we created the UTC to be able to manage the lower levels of acuity. So the patients who previously would have gone to the ED department who might have a minor injury or a minor illness, so that they can come to a different side of the hospital. And we've tried to bring that under the remit of a UTC. We brought GPs and clinicians together to manage that. As we now get to a position where we have much less COVID activity within the island, we are able to go back to a position where that activity can start to be managed through one emergency door, and so that we can start to resume back to normal in terms of how that emergency department previously would have functioned.
Okay, thank you for that. It's absolutely clear.
Thank you.
Thank you. So I just wanted to ask some questions about the Nightingale wing. So what has been the real impact of the flooding of the Nightingale Hospital caused by the recent heavy wind and rain?
So it hasn't been. We're using the Nightingale as a clinical education as an education centre at the moment, which has been really useful. The flooding, whilst it was an issue, has been dealt with and is causing us no further issues. And the roof has been fixed, so we are optimistic that going forward that fix will hold and that we will have no further issues.
Okay, thank you. So also, when will the fire certificate finally be in place? And can you respond as to why the fire service experts seem to have not been included or brought in at the start of the project? Thank you.
So my understanding that the fire service was involved right from the start of the project, because the project was coordinated by the DG for Justice and Home Affairs. So fire was an integral part of it, is my understanding, but I will need to clarify that with Rose.
No, it is the case.
And because Rose has been our executive lead on the Nightingale. My understanding is that a certificate has been issued.
Yes, I've been advised of that.
So I think that is now resolved.
That was a fairly recent thing, though, wasn't it?
The fire certificate, I think I recollect is within the last couple of weeks, yes. But I'll have to come back to you on that.
Okay, thank you. So what is the latest on the use of the Nightingale? Are there plans now in place to have it until a fixed date to support the island through the winter months? And if so, what is that date? Thank you.
Do you want me to say something? I can pass over. So yes, I know that negotiations are going on to secure the Nightingale over the winter months, and it is felt that we will be able to do so. Those negotiations are being headed by GHG. So the plan is to have it over the winter months. And as to what is going on there now, the Director General told you that our education centre was taking place there because COVID has meant that its premises here in Peter Creel House were utilised as a control centre for the COVID emergency. So as a temporary arrangement, the educational services are being held there, just to ensure that they continue as before.
And we have a clear winter escalation, and we have a clear escalation plan for how we would use the Nightingale if we were compromised by the volume of presentations of COVID. I mean, I think we've planned for the worst, we hope for the best, but it's a great contingency for us to have around our preparedness.
Okay, thank you. I'm mindful of time, so I'm just going to hand over back to the chair. Thank you.
Thank you, Karina. I just wanted to double check. The list of questions is still endless. So what I'm minded to do actually now is, if this is okay with the health team, is I know that Deputy Pamplin had one other question that he wished to ask, and then maybe just ask, if there was anything further that the other three panel members wanted to ask as final questions, if that was okay with you, Minister, and the team. Thank you.
Yes, that's okay, Chair.
Okay, I'll then ask Deputy Pamplin for his question, and then if anybody else wants a question, if they just want to indicate in the chat, that'll be good.
Great, thank you, Chair. Minister, I don't know if Dr. Muskett's still with you, but I want to return back to the question of the threshold for periods of isolation, which has obviously featured heavily in the debate we had last week and could quite possibly return to the Assembly next week. So based on the updated medical advice and the new data that's coming through to you, Minister, from STAC and Dr. Muskett and the Medical Officer of Health, will the threshold for periods of isolation pending the test result change given the early asymptomatic cases, or if more positive cases are discovered as passengers go up, and as Dr. Muskett mentioned, if those asymptomatic become symptomatic, so they become pre-symptomatic cases, what will be the threshold for reviewing that? So medically, the advice will change, that it is advised that people do isolate while they're waiting for those tests results. Thank you.
So, Deputy, that's a very specific question around what advice might be given. So if I might pass over to Dr. Muscat and ask him to address that.
So the current advice is based on the current prevalence of COVID in the UK, which is estimated to be a PCR positive prevalence of about 1 in 1,100 individuals, of whom about half would be asymptomatic. And the sort of estimated risk from not quarantining for the 24 to 48 hours after having a PCR pending results is of the risk of onward transmission from those individuals is very low indeed. So we felt it was safe to continue with a PCR without quarantining for this period. What will happen, though, as we go forward, and improve our on-island capability to test at scale, is that period between taking the swab and getting the results will get shorter and shorter, and will at some point be of the order of 12 hours or less. We hope those are our calculations anyway. So the risk from the non-quarantine period of onward transmission would be even less. As you are probably aware, it is difficult, although it is ideal, it is difficult to actually get a significant number of passengers having a PCR for travel. That requires the sort of a setup in different jurisdictions over which we have little control. That relates to the UK, and we have, as you know, stratified countries by, if you like, their prevalence. So those countries which, on balance, have a risk of COVID approaching that of the UK, and so not particularly requiring any additional steps in going into the UK, are being asked to have a PCR plus no quarantine coming into Jersey, which is of course more than what is happening to entrants from those sort of green countries, if you like, to the UK, and indeed across Europe. If the prevalence of the country of origin of a traveller is higher than the first tranche of countries which are sort of in our green stratum, if that is higher, if they're in our amber stratum, then we are asking individuals to have a PCR on day 0, self-isolate for 5 days, have a PCR on day 5, and then wait for a negative result before venturing forth. And if, in fact, the risk is even higher than that, and they follow into a red stratum, then they have a negative. They have to have a PCR on arrival and self-isolate for 14 days. And that sort of approach will be applied to people, for example, coming from the United States. And the reason we do a PCR at day 0 for those individuals is that if they are positive, then we would want to contact trace their fellow passengers.
Excellent. Ivan, again, thank you for that, as ever, reassuring. Going to throw now to Deputy Alves, who's got some final questions.
Thank you. So my final questions are around the expenditure. So last year, the States Assembly approved a total of just over 211 million heads of expenditure for HCS for 2020. Can you tell us how much you have spent to date? And can you tell us how much of that has been spent on COVID-19 related matters, please? Thank you.
Could I ask Lauren to come in and give us those figures?
Certainly you can. I'm just pulling up my file as to where we are. To date, we have spent around 13 million on COVID-related activity. We are still obviously reviewing all of our business as usual accounts just to make sure that we have captured everything, and we will then be submitting a final business case to ensure that those costs are submitted to Treasury. I'm sorry, I'm just having a little IT issues here. My camera isn't working.
Are you able to tell us how much has been spent in total then? So 13 million is at the moment on COVID related, but how much in total?
Yes, I'm just pulling up my report for you.
Thank you.
Okay. So our year-to-date budget is 116 million, and we actually have spent 126 million. But as I say, there's year-to-date that includes 5.7 million of COVID-related activity.
Okay, thank you. So according to the efficiency plan, HCS was due to make 9 million's worth of efficiencies in 2020.
Yes.
How many of these efficiencies have you achieved to date? And are you aware of any efficiencies you'll be asked to make next year?
Okay, so year to date, we have actually delivered, sorry, just getting the numbers up, different files. We've actually delivered 2.6 million of efficiencies against a year-to-date target of 4.5 million. COVID clearly disrupted a lot of our schemes here, where there were certain efficiencies that we were unable to deliver because of capacity reductions, etc., particularly around the income generation schemes for private patients, etc. Our annual target is 9 million. We're currently forecasting to deliver 7.3 million of that this year, and our efficiency target for 2021 is £5 million.
Okay, thank you. And my final question on this section is, in the previous government plan, you requested a further 4.8 million for 2021 on top of the 3.2 million requested for 2020. Do you still intend to request those funds in this year's government plan, recovery plan? Thank you.
Yes, we do, and that is to enable us to fund some growth across HCS going forward, both for this year and next.
Okay, how will that impact on the efficiencies? Because obviously you're under your target, so will that offset them?
Some of it will, yes, it will. And so what we'll be doing is having a look at the efficiencies going forward and seeing what growth that we will have to use to substitute for those efficiencies.
Okay, thank you. I'm not sure if there's any other member that would like to ask any other question.
Just briefly, if I may, we've got a chart here of expenditure from 2019 through to 2020, but there are some big amounts on there. There's £20 million plus in several places. Wonder if it's possible, though, without going into micromanaging, to have a breakdown of those lump sums, so it's easier to identify what gets spent where on what. It's to find a breakdown.
Yeah, we can provide a breakdown. We're happy to do that. I mean, some of it is because of our, I'm sure, and Lauren will expand more, our financial information and how we present that. But Lauren, I'm sure that we can pull something together. Yeah. Oh,
absolutely, yes. If I know, if you can provide me with some detail of how you would like that broken down, I can happily pull that together for you.
Thank you.
Okay, that's lovely. It's now, well, edging towards 11:45. So I think it's thank you very much to those that have provided us answers and their presence this morning. And hopefully we'll have another public hearing in the very near future. We didn't manage to get through all of our questions and our question areas, but I think that's the time that we're currently in. There's so much to ask and there's so much information that we want to get across. So thank you very much to all those staff and to the Minister and Assistant Ministers from Health, and thank you to the Scrutiny panel. We'll speak again soon. Thank you very much.
Thank you, Chair.
Thank you, Minister. Thank you, team.
We've left.